Good afternoon, everybody. Today I'll be talking about the complexities of risk assessment, specifically looking into opioids, drug interactions, and designer benzodiazepines, and how they come together and pose a potential risk. My name is Austin Mondloch. I'm a pharmacist. I'm in my second year fellowship with Aegis Sciences Corporation. A big part of my passion and research in my job has to do with academia, toxicology, and drug information. I just want to let everyone know that this presentation is the property of Aegis Sciences Corporation and is intended for informational purposes only. A couple objectives that I'll read off is I want everyone to be able to recognize effects of CNS depressants on the body, identify possible combinations of drug classes that cause CNS depression, also review strategies for identifying potential drug interactions, and then finally highlight the danger that designer drugs may pose in CNS depression. A reasonable question to start off is why the number of fatal and also non fatal overdoses continue to rise. What we see in this mechanism where an overdose happens is something called CNS depression or central nervous system depression. This happens from we can see this happening from one drug, but we often see it when different combinations of drug overwhelm the person's system. Typically, we see this as an altering of neurotransmitter activity within the brain. Typical neurotransmitter we see being increased with this effect is something called gamma aminobutyric acid, or GABA, which is commonly referred to. So when prescription or even illicit substances enter the body, they may cause this CNS depression. This CNS depression can affect the brain and the lungs, and then can also decrease the oxygen that is then delivered to the brain. This phenomenon is called hypoxia and may lead to short and even long-term effects on the patient. Some of these effects are brain damage, putting the patient into a comatose state, or an overdose leading to possible death. I'll be talking about some causative agents that we'll be looking into. So opioids is something I'll be touching on, benzodiazepines, alcohol, also some non-benzodiazepines as well that might be indicated for insomnia. I'll also touch briefly on some mental health medications like tricyclic antidepressants and antipsychotics, specifically first generation antipsychotics, and then also a little bit on muscle relaxants, and then also designer drugs as mentioned before. With opioids, opioids are commonly prescribed medications. They're typically prescribed for pain. They hit a receptor in our body called the mu opioid receptor, and they are classified as a CNS depressant. And when an overdose occurs on an opioid, or an opioid in combination with another medication, we may see symptoms in the patient such as loss of concentration, confusion, reduced heart rate and blood pressure, and slowed breathing. And then on the slide, I have a few examples of common opioids that are prescribed, such as hydrocodone, oxycodone, morphine, hydromorphone, and fentanyl. So, like I said, opioids can be classified as a CNS depressant through its mechanism of action. CNS suppression and GABA, like GABA I mentioned before, this gamma aminobutyric acid, this is a molecule that basically tells the body to slow down. That's why it affects a patient's breathing. And what we've seen in recent reports is in patients dealing with opioid related overdoses, we also see combinations of gabapentin as well. Gabapentin is a prescription that patients can get, and we see this combination of the two that I'll also be talking about this combination a little bit later in a case study. But there's also research that shows that the combination of the two may lead to some CNS depression effects. Benzodiazepines is another drug that I'll be talking about quite a bit. They're commonly prescribed in the United States. They can be prescribed for quite a few indications such as anxiety, insomnia, muscle relaxation, relief from spasticity, and epilepsy. And then some common prescriptions that we may see prescribed for our patients are alprazolam, diazepam, lorazepam, and temazepam. Additional causative agents, like I mentioned, barbiturates such as phenobarbital can cause sedation, and then also ethanol, or alcohol can cause these effects as well. These effects work on GABA receptors, but they can also inhibit glutamate, which is an excitatory neurotransmitter. Gabapentins is like an inhibitory neurotransmitter, while glutamate is an excitatory. So it can increase that inhibitory and then also stop the excitatory. So again, it's these kind of the compound effects and different mechanisms how that can cause this, the sedation, the CNS depression, and the reduced breathing, and possibly an overdose. Additional causative agents, like I mentioned, Z drugs, which are non-benzodiazepine sedatives. Typically, they're used for insomnia and also have activity at the GABA receptors, just like benzos do. They work a little bit differently, but they still have that GABA activity. Some examples include zolpidem, ensopleclone, and zaleplon. And then, like I mentioned, there are some mental health medications such as tricyclic antidepressants and first generation antipsychotics. They have some anticholinergic effects that, especially in combination with these other causative agents and other CNS depressions, in combination, they can definitely lead to possible CNS depression overall in the patient. Additionally, the FDA warns on the use of CNS depressants in combination with substance use disorder medications such as methadone and bupropion. Both of those medications work at the same receptors as opioids. So it's important for prescribers to be aware of what their patients are taking. They may be prescribed methadone and bupropion or buprenorphine, excuse me, for their opioid use disorder, but if they're also taking additional agents that may cause CNS depression, it may have a compounded effect with these medications in combination. So, a little bit on designer drugs, or specifically designer benzodiazepines. The issue with these medications is that they're illicitly manufactured in various labs. There's very limited clinical studies on these drugs. We're not giving patients designer benzodiazepines to see what happens. We just don't have that data, and we don't have those studies available. So there's very little limited clinical data, and it's very difficult to quantify the potency. Depending on how these medications are manufactured, sometimes it leads to lesser or even greater effects when compared to, I guess I'll say, normal prescription benzodiazepines. So it's hard to quantify the potency, but we have seen some very toxic effects from these medications. And it's difficult to quantify because these medications are made to to potentially increase abuse potential, but to also bypass regulation as well. So again, here's some examples of some potential designer benzodiazepines. Like I mentioned, the ingestion of these along with a benzo or an opioid, especially as a co-ingestion, may lead to the CNS depression. So by themselves, they can cause CNS depression, but especially in combination, we see that. And then the next slide, I'll talk a little bit about a study. So overall, these drugs have a profound effect on the patient. So it's very important for providers to be aware of what their patients are taking, and Aegis strives to help practitioners be aware of what their patients are taking and help to identify these molecules that these patients may be ingesting. So here's some examples, more examples of designer benzodiazepines. These designer benzos are medications that Aegis can track. We're able to analyze these when we get a patient's sample. We have seen some our own case reports where these medications have shown up, and specifically flualprazolam. Our student this month recently did a journal club on a case on forensic studies. So it looked at patients that unfortunately passed away after taking flualprazolam. And like I mentioned, these designer benzos can cause CNS depression, but this study also had a table with very various prescription and illicit substances that were also in the patient's system. So again, it's this compounded effect of these patients taking the designer benzodiazepine, but also these additional CNS depressants, like I mentioned before, morphine, fentanyl, methadone, are all opioids, and then also that alcohol, and then additional prescription benzodiazepine may have this compounded CNS depressant effect when in combination. Another trend with designer drugs we've been seeing is xylazine. We've been seeing it cut into fentanyl, and unfortunately, xylazine has a unique mechanism of action where it does not hit the same exact receptor as opioids, but it still can lead to sedative and CNS depressant effects. The reason why I mention this is that when this medication is in the body, it does not respond to Narcan or naloxone, which makes it extremely dangerous in overdose cases because we have a reversal agent, but if xylazine is not responding to Narcan, it's unfortunately has led to overdose and deaths as we've seen this on the hitting the streets. So we're going to be talking a little bit about a case study with potential CNS depressants and then also some drug interactions in a patient case. And then the next slide, I have the drugs highlighted more in a table form. So these medications, so atizlam is a designer benzodiazepine, gabapentin, oxycodone, and bupropion are all prescription medications, but we see that a lot of these prescriptions, when taken in combination, may lead to potential compounded CNS depressant effects, and then also some drug interactions that I'll highlight as well. So first with gabapentin and oxycodone, kind of like I mentioned with a couple slides back, gabapentin and oxycodone can lead to these compounded CNS depressant effects, especially when taken co-ingesting, when patients are taking both at the same time. This is a moderate risk, but it's still a risk overall for these CNS depression effects because they still affect the neurotransmitters, may cause an increase in GABA, and may lead to an overdose, this decreased breathing, and potentially mortality along the line. So it's all prescriptions to be aware of what our patients are taking. Another interaction that we can show our prescribers through our Interact RX technology, we're able to see that bupropion can interact with oxycodone. So bupropion works through this pharmacokinetic interaction where it inhibits cytochrome P450, which is liver enzymes in our system that help to metabolize drugs into active forms and help. It allows our bodies to then utilize those drugs and also allows the metabolism to flush the drugs out of our system as well. So adherence to bupropion is a concern. Sometimes when the patient is taking this medication, they're taking oxycodone, and because it's not being metabolized to its more active form, the oxymorphone, the patient may not be getting the analgesic effects or the pain relief that they're hoping to get. So this may cause the patient not to get relief or even take more of the medication than they're supposed to because they, either don't think it's working, or if, like I mentioned, if adherence is an issue, they may stop taking bupropion and then have this increased effect of oxycodone all of a sudden if they're taking more than they're supposed to because they're not getting these effects that they want. And then on the next slide, I have a little bit of a representation of what this looks like. So like I mentioned, the CYP enzyme, the CYP2D6, transforms the oxycodone to the more active form oxymorphone, but bupropion can inhibit that conversion. So like I mentioned, the patient isn't getting the analgesic or pain relief effects they're expecting, so they may take more than needed, which may cause issues down the line. So this isn't necessarily a compounded CNS effect like I've mentioned before, but it's a drug interaction they may cause issues down the line. Additionally, with drug interactions, so alpha hydroxyatizolam is the metabolite of atizolam, which is a designer benzodiazepine. As I mentioned before, it may have CNS depression effects, but especially in combination with these already other CNS depressants that the patient's taking, such as the gabapentin and the oxycodone. So all these medications together can unfortunately overwhelm the patient's system and lead to a possible overdose. And just again, a little bit of a representation of what this metabolism looks like. With Aegis, we look at a lot of samples. We look at a lot of urine samples where we see the metabolites of the drug. So we may see more of the metabolite. But again, this shows with this alpha hydroxyatizolam in the patient's system, we can trace this back to the parent drug and see that the patient ingested atizolam, which is that designer benzodiazepine. And then down below, we have a couple metabolites of the more typical prescription benzodiazepines that we may see. So overall, overprescribing is something that I want to touch on. Overprescribing is inappropriate polypharmacy or the unnecessary or excessive prescribing or overprescribing of medications where these medications may interact with each other, kind of like what we saw with bupropion and oxycodone. So the prescription drugs can interact with each other, but they can also interact with other medications such as over-the-counter medications, food, supplements, vitamins, and these interactions between the drugs can lead to falls, cognitive impairment, or possibly worsen the effects of a disease state that the patient's experiencing. So, like we saw before with the CYP450 enzymes, we may see some pharmacokinetic interactions that may cause the patient a worse effect, unfortunately, like I mentioned previously. And these interactions, they can be mild to severe, but they're often preventable. I think the first step is to be aware of what our patients are taking and then be able to manage that. With the case of bupropion and oxycodone, there are potential other options that the prescriber can give so that we don't see that drug interaction, because as I mentioned before, that interaction can lead to potentially um, potential negative effects for that patient. So, like I said, it can lead to adverse effects. And then another example, when I talked to you about buprenorphine before, a patient may be taking another CYP450 enzyme, where in this case is a CYP3A4 inducer, such as carbamazepine. This may lead to decreased efficacy of that medication and may lead to withdrawal symptoms, and then also potentially increase that patient's risk for non-medical opioid use. So overall, in conclusion, through Aegis Sciences Corporations, we can provide providers the tools they need in order to see what their patients are taking, help and guide them in terms of how they can manage their patients' prescriptions, make them more aware of possible CNS depressants that they're taking that may lead to potentially adverse effects down the road. So again, our initial approach is at least identifying those potential drugs, and we're able to identify a lot of potential designer drugs, such as those designer benzodiazepines that may cause those toxic effects. But again, like I said, we're hoping to provide awareness and education on these possible risks that these medications may pose. Here's our clinical team. There I am in the upper right corner, and those are my references. Were there any questions? You can also contact your regional sales manager or the clinical team.